All right, party people, we are back at it with another question. Let's get it. So, if I was to give you a 6-year-old female with 1 week of itchy papules found on the arm, and she also had a similar bout of these 6 months ago, on KOH prep, there are pseudohyphae and single budding yeasts. For skin antigen test, she has a normal response to Candida protein extract. Also, a nitrotetrazolium assay is done, and there is a blue color. Now, of the option choices provided, which one would you choose? 3, 2, 1, boom. All right, let's spin the block, seeing why the correct answer is the correct answer and why the incorrect answers are incorrect. Let's get it. So, skin antigen testing showed a normal response to Candida protein extract. This rules out chronic mucocutaneous candidiasis. In that condition, patients have recurrent Candida infections from childhood. And skin antigen testing shows anergy. This means no response to Candida antigens. If that had been the diagnosis, the answer would have been a deficiency of cell-mediated immunity. Just to elaborate, even though that's not the case here, chronic mucocutaneous candidiasis is a T-cell defect. So on exams, the answer would be deficiency of cell-mediated immunity. A nitro blue tetrazolium assay reveals a blue color. This is normal. This means the diagnosis is not chronic granulomatous disease, which is caused by NADPH oxidase deficiency. In CGD, the NBT test would be yellow, meaning no color change. Also, you have to be aware that there is a DHR test, which is now the updated diagnostic method for NADPH oxidase deficiency. Between nitro blue tetrazolium and dihydrorhodamine test, pick DHR as the go-to test. Also, as a side note for CGD, this is usually X-linked recessive, but don't assume it can't occur in females. And it can also be inherited in an autosomal recessive pattern. So don't just rule things out based on inheritance patterns. For the deficiency of mucosal immunoglobulin, this refers to IgA deficiency. Normally, this is in teenagers or older individuals with recurrent sinopulmonary infections, such as sinusitis or pneumonia, possibly asthma, eczema, or rhinoconjunctivitis. Associated conditions may also include autoimmune diseases like vitiligo or pernicious anemia. They might have a history of giardia or anaphylaxis with blood transfusions. That is not the case here. Next up, we have deficiency of cell-mediated immunity. Again, this would be the answer for chronic mucocutaneous candidiasis, which we've ruled out. It's also seen in Wiskott-Aldrich syndrome. This is X-linked recessive, and normally it presents in boys with a triad of eczema, immunodeficiency, and thrombocytopenia. You'd see symptoms such as petechia and nosebleeds. It also can be seen in DeGeorge syndrome. This is thymic aplasia. Once again, not the case here. Moving on to impaired leukocyte adhesion. This refers to leukocyte adhesion deficiency due to CD18-LFA1 integrin deficiency. Classic features include delayed separation of the umbilical cord, recurrent skin infections without pus, and decreased neutrophils at sites of infection. Once again, not applicable here. Now, inability to produce superoxide is referring to CGD. Normally, in CGD, molecular oxygen is converted by NADPH oxidase into superoxide. This is the first step in the respiratory burst. Following, superoxide is converted by superoxide dismutase to hydrogen peroxide, which myeloperoxidase then converts into hydroxyl halide radicals, aka bleach. Once again, this is not the diagnosis. Finally, reduction into hydroxyl halide radicals. This is the correct answer. So myeloperoxidase, MPO deficiency, this condition classically presents with recurrent candida infections, though many patients are asymptomatic. Unlike CGD, MPO deficiency does not cause susceptibility to catalase-positive organisms. These patients will have a normal NBT test. Just remember, MPO deficiency is impaired production of hydroxyl halide radicals with a normal NBT test, and if symptomatic, recurrent Candida infections. In contrast, CGD will have a yellow NBT test, and the DHR test is abnormal, susceptibility to catalase-positive organisms like Candida, E. coli, Serratia, or Pseudomonas. So if you're contemplating between CGD and MPO, know that CGD, yellow NBT, abnormal DHR, catalase-positive infections. MPO, you have a normal NBT, normal DHR, no catalase susceptibility, possibly recurrent Candida infections, if symptomatic. All right, that's it for this one. Go crush it.